Good evening, everyone. Welcome to the Royal and welcome to Conversations at the Royal. Thank you for joining us tonight. I'm Karen Monahan. I'm the Communications Manager here at the Royal, and it's really great to see a lot of some familiar faces here and a lot of you coming out tonight. So our topic tonight, as you can see, is the Mental Health Act 101. So what families need to know to navigate the mental health system. It's my pleasure to introduce Sherri Cannon. She's going to tell you a little bit about herself. So I'll just share that Sherri has been with the Royal for a few years now. She is a nurse, and she's spent some of her time helping to educate and share her knowledge with staff at the Royal, and then has recently taken on the role as the manager of patient care services for our geriatric program. So welcome, Sherri, and I'll turn it over to you.
Thank you, Karen, for the introduction. We have lots of information to learn tonight, but I am going to keep it more family-oriented and community-oriented. That was really what I wanted to do tonight. So I'm going to share a lot of my experiences that I've had working with families and working with clients, and bring in navigating the mental health system and some basic knowledge around the Mental Health Act as well. So a little bit about myself. I have always been a mental health nurse. Nursing was my second career, actually. I was a nutritionist for my first career. And when I was, I think, 30, I shouldn't date myself though, I went and decided to go back to school. And I went for nursing, and I knew right away that mental health nursing was going to be my calling. So I started on the acute care wards at the General Hospital in the Civic, and I worked the inpatient and I worked psychiatric emerge. And what we have in acute care is we have all diagnoses in mental health, and we also have ages from, I had patients from 17, 18, all the way to 108. What is very interesting about working in acute care is we have all of those patients together on one floor. Now, there are good and bad things about that for sure, but it really gave me a wealth of experience that I saw all the different areas of mental health through the adult system. While I was working there, I really wanted to get experience with youth and children. So I also went to work in mental health at CHIO. And I worked with clients. I had clients as young as 6 and up to 17 years of age. I worked in eating disorders there on the inpatient unit, outpatient unit. I worked in day hospital, and I really enjoyed my time there. In about 2011, I got the great opportunity to go work in the community with the Ottawa Hospital. And I transferred over into First Episode Psychosis program on Bank and Riverside. There's a clinic there. And I was able to work with youth and young people and their families experiencing their first episode of psychosis. This is really where my interest in this topic arose, and when the call went out for speakers, I happily put up my hand and I was accepted as a speaker. While working with clients, young clients and their families, the feedback and the stories that I heard from the families and their experience getting care for their loved ones and entering the mental health system for the first time and trying to navigate that on their own was a lot of the time very heartbreaking for me to hear that. And at the clinic, we really tried to support them, but by the time they actually got intensive services, it could have been years that they were dealing with this on their own in the community. And that absolutely struck a chord with me. I've always had that interest in improving the mental health system and also educating people about the mental health system. There is support out there. It can be hard to find though. And I'm going to share with you a lot of the feedback that I got from those families. And that is where a lot of their feedback is what I've used to make this presentation tonight. I am currently the manager of Geriatric, so a bit of a big change in the past few years from first episode psychosis. I ended up doing 2 years in geriatric outreach in the community, and I also fell in love with the geriatric population, which surprised me a little bit. So now I have 2 loves. I have youth and first episode psychosis, and I have geriatrics. And that's one of the best things about nursing, to be honest with you, is throughout your career, you can do so many different things and have so many different specialties. So I feel very, very blessed to be in this profession. I've only been with that program for about 3 months as manager. I spent 1.5 years recently as the educator for the hospital. And doing that, I've done a lot of presentations, so at least I'm really good with PowerPoint right now. I will warn you as a warning, though. Although I have this nice PowerPoint, I will ramble a little bit, and maybe a surprise slide will come up, but I promise we will get through the information tonight. So I'm going to talk a little bit about what I learned in those years working with the families. So when I was thinking about this presentation, I was really going back. I worked with those families for 4.5 years, and I carried a caseload of about 30 clients. But that was only part of my work, because for every client, I also had a family that I worked with, and I worked just as closely with the families as I did with the clients, sometimes more, especially in the beginning. So what did the families tell me about their experience? They told me that the mental health system is cumbersome. It's big. It's meandering. It is difficult to navigate. They talked about very long wait times. For the clinic that I worked in, it was 9-month wait time when I started there. Now that's 9 months because the clients came from acute care. So they were briefly stabilized in acute care and they were discharged home. Now remember, most of my clients were 16 to 24, so they were living at home. And they had a 9-month wait until they could get intensive services. That's a very long time. That can seem like an eternity when you're dealing with that. They talked about a lack of information. And a lot of the information that they were able to get was on the internet. And a lot of that information is very scary depending on your source. Okay? They talked about a lack of support. They said that that was one of the number one things that they wanted at that time. Information was great, and what the doctor was telling them in medical terms, okay, they were really trying to understand that. But what they wanted was support. That was what they needed. They talked about a lack of knowledge about the system. They talked about a lack of knowledge about the Mental Health Act. When you're not sure what you're dealing with, it can be very, very scary. They also were very shocked when they realized the lack of resources that we have in healthcare in general, but especially in mental health. Now, every year it's getting better, absolutely. The government is really starting to realize the need, and we have a lot of programs through the Royal. We have a lot of celebrities. We have programs like Do It for Darren. We're really getting mental health out there, and people are talking about it, but we still have a long way to go. That realization for them was very, very shocking, and it made them feel very, very vulnerable. So what did they feel? They felt fear. They felt fear for their loved one. They felt fear for themselves. They felt fear for the future. Anger. They felt angry. That's why I have the exclamation mark there. In the beginning, there was a lot of anger. There was anger that their loved one had this mental health illness. There was anger at the system for not being as helpful as it should be. There was a lot of anger. There was frustration. Lots and lots of frustration. At times, there was despair. Absolutely. Disillusionment, that went along a little bit with the realization of how the system is right now. As I said, it's improving, but we have a long way to go. They felt helpless. They wanted the best for their loved one, and they tried so hard, and they felt helpless at times. And they felt a lack of control. One of my families described it as just feeling like you're spinning in outer space. It's like it's like you've been pushed, and you know how you keep spinning in outer space, and they can't grab onto anything, and they can't stop. And that's what they were telling me that they were feeling. So with all of this, how did they respond? Everyone responds differently. However, over those 4.5 years, I observed that most families progressed along sort of a pretty typical trajectory where they experienced a whole bunch of different things as they went along. And when I was putting this together and remembering, I felt like they went from a very negative place and eventually to a more positive place. They went from being reactive to proactive. So they went from reacting to everything that was coming along, which I thought was very normal, reacting to everything, right? To being proactive, and I'll talk about that, to being very proactive about things. Eventually, most of the families reached a state of acceptance, and they were actually able to support each other. And that was a really wonderful thing to see as a clinician. The time frames for this trajectory were very highly individualized, and they were dependent on a lot of factors. They were dependent upon the family unit themselves. They were dependent upon the illness of the individual. They were dependent upon a whole bunch of different things. How much support the families had of themselves. Some family members joined parent support groups, and we definitely encouraged that, like Pleo. We have Natalie here from Pleo. Thank you so much, welcome. That is a support group for parents. Some families lobbied the government and their MPs for more resources. I thought that was amazing. It was really, really wonderful to see that. It was a lot of work, though. And they would give me feedback like, I never thought that I would do something like this. I didn't think I had that in me. And the change in them to actually feel being proactive instead of reactive and really feeling like they're trying to change the system was very, very helpful for them. One family member started her own very popular support group. And a lot of the families volunteered. When they got to the road of acceptance on their journey, when they got to that part of their journey, a lot of them really wanted to give back to the system. So I saw them going out for the Shoppers Drug Mart Women's Run, organizing teams for that. I saw them volunteering at the crisis line in their off time, things like that. They wanted to give back to the system that they eventually felt was there for them. So finally, this is what really guided my presentation tonight. What did the families tell me would have been helpful for them during their journey? They talked about having knowledge of the system. A lot of my families, this was the first time that they encountered mental illness and the mental health system. So they said that having a knowledge of that and the services and the supports would have been really, really helpful. The biggest thing, they wanted support in navigating the system. As I said, the mental health system is very cumbersome. There's a lot of, I'll talk about the Act, there's a lot of technicalities, there's a lot of different services out there, and a lot of times you're not sure what service is appropriate for you in the beginning, you're not sure where to apply, you don't know if you need a referral, there's all these different processes. So having support in navigating that system is what they really wanted. They wanted to be more included as part of the treatment team. They felt that, especially in acute care, not so much when you got into a clinic such as mine, but in acute care, it was like, okay, we've got your loved one now, they're behind locked doors now, we're gonna take care of it, and we'll let you know how everything's going, if you're lucky to catch the doctor on that day. They felt that they wanted to be included as part of the treatment team, and that helped their sense of control as well. They wanted access to peer support. They wanted to talk to other families who were either going through what they were going through or had gone through what they were going through. They wanted some hope. They really wanted some hope. They wanted someone to say, yeah, it really sucks right now, but guess what? It's going to get better. Because I know, because I was there. They wanted reassurances about the future. Now, in mental health, this is very difficult to do. Much easier if someone breaks their leg. We take them to the hospital. The doctor says, okay, we're going to do an x-ray. You can see on the x-ray, there's your fracture. We're going to put you in a cast. The doctor says, I've seen this 2,000 times, this fracture. 99%, I'm sure, that after 6 weeks in a cast and a few weeks of physio, you're going to be good as new. With mental health, it's the opposite. Everything is gray. And we don't have a lot of answers yet. So giving reassurances about the future was very difficult. But at the same time, what we could do, what we should do, is give hope. We might not have a lot of answers, but we should be giving hope. They wanted support also with advocating for resources. All of a sudden, okay, well now you need to apply for ODSP, and you don't know how to do that. That's the Ontario Disability Support Program. But then you go to do that, and then they tell you, no, you have to go on social assistance first before you can get to ODSP. Well, how do I do that? But nobody tells you that, right? And how do I apply for housing? Well, that wait list is actually 5 years. Well, how do I get on the urgent list? They needed someone to tell them all about these. First, where to find the resources. Second, how to navigate those resources. There's a lot of support out there if you can find it. That was a big sense. It also fueled the frustration and the anger because there's a lot of resources out there, as I said. How do you find them? How do you get them? They needed someone to advocate for them and help them. So that is how we got here tonight. My experiences with the families. And it was absolutely, as I said, it was a real eye-opener for me, having working in the system and understanding the system so well. You almost get to the point where, oh, well, everybody knows that, right? And to understand that, no, we don't know that, and we need to communicate that. When I was preparing this presentation, this is why I'm going to do a brief history of mental health, because I know the brief history of mental health very well. And I almost jumped right into the Mental Health Act, and I realized, no, there's a lot of people that don't know the history of mental health. So I was lucky enough to find resources, so this is all geared towards mental health in Ontario and in Canada. A lot of times when you do research, you can find a lot of information about the US, the UK, and some of it's relevant, but I was really excited that I was actually able to find actual information about Ontario and Canada. So history of mental health in Ontario. And I actually learned a few interesting facts myself, and it's one of the wonderful things I love about making presentations, because I always learn something as well. Until the mid-1800s in Canada, the mental health patients were either kept at home with the families or they were placed into jails. I was very surprised about that. As you know, the jails were not a very nice place to live, to be. In 1839, the legislature of Upper Canada passed a resolution authoring the building of the first, what they called, lunatic asylum. Now that's language we would never hear today, and I'm very happy about that. But in the research it calls it this, so I am referring to that because that is the research. If you can imagine, this was actually supposed to be a good intervention. Historically, the mentally ill were being cared for by their families. Back then, most families lived on farms and agriculture. So we didn't actually see a lot of the mental health patients. They were at home. You might know them if you have them or you had a neighbor. It wasn't very visible. It's not like it is today. So they decided to build, in 1839, this lunatic asylum in Ontario, and they were going to take all the mentally ill people and they were going to house them in the lunatic asylum. 2 years went by, and no progress had been made on the asylum. So there was an old jail. There was an old jail building, and it was unfit for prisoners. This is how decrepit this building was. But somebody came up with the idea that we were going to use this as the lunatic asylum. So they gathered up about 70 of the mentally ill in Ontario, and they placed them into this lunatic asylum, our very first one. Now, keeping in mind, this was actually thought to be proactive at the time. We were going to take them out of the jails, and we're going to, because they had to move the prisoners to a nicer building, right? So, and we're going to put all of our mentally ill into this asylum. There's actually a quote from someone who went in to this asylum in 1845, and he was actually an advocate for mental health, and his name was J.H. Tuke. And he wrote, "It is one of the most painful and distressing places I have ever visited. There were perhaps 70 patients upon whose faces misery, starvation, and suffering were indelibly impressed." Now, the asylum was meant to be custodial only, meaning that these individuals were to live there. But if you remember, up until 1950s, we didn't have any medication at all for mental health. And the treatments, which I'll talk about in the early 1900s, were not very effective except for one, and they were pretty barbaric. So we didn't have any treatment. So we decided that we would just put them all together and they would live all together. Now, this asylum was publicly funded by the government. So municipalities thought, what a great idea. We can take our homeless, we can take our individuals that are taking up a spot in jail and we're paying for them, and we're going to move them to the asylum. Okay? Despite the terrible conditions, it was still actually for the person and the families and everyone, it was viewed as being preferable to what was happening before. As the late 1800s and into the early 1900s, industrialization started happening. And what happened is that we had a lot of people move into cities. As families moved into cities, the mentally ill became much more visible. We saw them more, right? They weren't living with grandma on the farm where no one could see them. They were right there in front of you now. To address the issue, they decided to build the London Lunatic Asylum. And it was built in the late 1800s, early 1900s. And they went big this time. This wasn't 70 patients, this was over 1,000 patients in one building. It was the third largest asylum on the continent. Now remember, asylums, this was becoming very popular. So there were these buildings, these institutions, they were popping up everywhere all over North America. And in London, we had the third largest one. Again, as I said, at that time, there was no medication for any mental illness. We had none until the 50s. The treatments tried in the early 1900s were a bit barbaric. Actually, some of them were a lot barbaric. But what happened in the early 1900s is finally physicians got interested in mental health. Because as we know, we live in a very medical model that is very driven by physicians. So the physicians decided that they were going to treat, or even better, cure mental illness. So now we had physicians treating patients in the asylum. The one good thing that came out of those early years, I know people can have a bad view of ECT, which is electroconvulsive therapy, but it's very, very effective therapy for mental illness, a lot of different diagnoses, and it is still one of our number one effective treatments today. So that is a good thing that came out of that. They did a lot of other things. They would submerge people in ice baths to try to shock the illness out of them. They would give huge doses of insulin and put them into a coma to try to shock the illness out of them. We had sensory deprivation, we had sensory overload, we did a lot of different things. In the 1950s, well, that saw the first medication come out, and that was Thorazine. Now, Thorazine is a typical antipsychotic with a lot of nasty side effects, but it actually helped a lot of people. And this really started to transform the mental health system in Canada. With the medication, finally, individuals were starting to improve. And the realization started that maybe we can discharge a patient. Because before, you would go into one of these institutions and you would live there. You would not leave because you would not get better, right? With medication, we started to have hope that we do not have to have people living in asylums all the time. So care began to be transferred outside of the institution. And greater restrictions were placed on what we call committing people into these institutions. It was much harder to send Mr. Smith to the institution to live forever. It was much harder because we had hope. We knew now that we had medication, we had treatment, we could make people better now. This statistic absolutely shocked me when I found it. In just 16 years, because as we know, things don't move very fast, right, in government and in systems. But in just 16 years, the number of beds in Canadian psychiatric hospitals decreased from 47,633 to 15,011 in just 16 years. That is incredible. At the same time, the number of beds in acute care increased. So this is where, during those years from 1960 to 1976, this is where we have the change from individuals being treated in psychiatric facilities. We're now treating them in the community, and we're treating them in the acute care hospitals. And that is still basically the model that we have today. Sounds great. But this when we make a big change like that, and we have that much change in only 16 years, what can you guess happened with everybody that was discharged into the community? Well, they didn't make the best plan for it, so we had very scattered services across, sort of patchwork services for individuals in the community. We didn't have as much support, although they were trying very hard, and they actually switched the funding. The funding that used to be very centered on the psychiatric hospitals was now changing, and so less funding was going to the psychiatric hospitals and much more was going to the community, but they were always playing catch up. So we had a lot of individuals that fell through the cracks, a lot of individuals that ended up with not the best outcomes, but we were still moving towards the system that we have now. So what is the mental health system today? Today, the majority of our mental health clients are served outside of psychiatric hospitals, outside of inpatient units, and in the community with very intense services. We have day hospitals, we have outpatient services, we have outreach services, we have ACT teams, that's the Assertive Community Treatment Team. We have a whole bunch of services. We have multidisciplinary teams in the community, and we are really trying to support the clients. Instead of in the past, you had one psychiatrist, and if you were lucky, maybe a nurse. Now you can have an entire team treating you, involved in your treatment. You can have social worker, you can have rec therapy, you can have occupational therapy, you can have nurses, you can have advanced practice clinicians, you can have nurse practitioners, and of course psychiatrists. And today we have only 4 psychiatric hospitals in all of Ontario. The Royal is one, We have CAMH in Toronto. We have Waypoint in Penetanguishene. And we have Ontario Shores in Whitby near Toronto as well. So big changes. So now we're going to talk about the basics of the Mental Health Act. So in all of that history, where does the Mental Health Act fit in? Well, historically, the Mental Health Act's main purpose was to define if and how a person could be detained against their will in an institution. And that's changed over the years, because today the Mental Health Act has two purposes. One is to protect the client's rights and freedoms, keep the client safe and free from unlawful detainment, but also to protect the public. So I think of the Act as wearing two different hats that have to come together and work together. The Act of today, though, is not perfect. It still centers around the involuntary inpatient admissions, which, as we know, which we just talked about with the history, is only a small percentage of the clients that we actually serve. So this begs the question, is the Act serving the needs of the new community-based model here in Ontario? Now that's a question for another time, but I want, as you hear about the presentation, just keep that in mind, okay? As I spoke about with the feedback from the families, having the basic knowledge of the Act that we do have right now can really help families in entering the mental health system for the first time, advocating for and securing services, protecting the rights of your loved one and the individual, ensuring the safety of the patient and the family, and helping everyone feel much more confident in the system and with your care providers. So this is what I see that the Act that we have right now can do for us. We're going to talk about a few key definitions just to help you as we get into the nitty-gritty of the Act. So we have a voluntary patient. So when we talk about, oh, he's voluntary or she's voluntary, it means a person is admitted to the hospital and they agree to stay on their own free will. So that's what we call a voluntary person. So a voluntary person might have passes to go out. They might have weekend passes. They might be able to come and go as they please, okay? They don't need a doctor to write the pass, okay? Now, on the other hand, an involuntary patient is a person admitted against their will. They don't want to be there because they exhibit signs of mental illness and or impaired judgment. So they need to be treated, but they don't feel that they need to be treated. They don't want to be treated. But we need to keep them in the hospital for their own safety. That's an involuntary patient. The third category of patient is an informal patient. So there's really two main categories for informal patients. So this is someone who's admitted with the consent of another person who has legal authority to do so. So we would see this with youth who are unable to make their own decisions, and their parents are making that decision that the youth needs treatment. We also see this in my program in the elderly. So someone who has dementia and they have a substitute decision maker making decisions for them. So they are informal. So substitute decision maker, SDM. This is a person who is authorized by the law to make decisions on behalf of another. There's different types of SDMs. So you can be an SDM for personal care. So that means that you would make treatment decisions, you would make decisions on things like medication, things like where that person would live, okay? You would buy their clothes for them, you would make those sort of decisions for them. So that's personal care. You can also be an SDM for finances and or property. So for an example, when my grandmother was not able to make decisions for herself, I was the SDM for personal care, which made sense with my medical background. But my father, who is an accountant, was her SDM for finance. Usually an SDM is a person that is known to the family. So it might be a mother, a father, a sister, a brother, a close friend, someone that the person knows. Unfortunately, we don't all have someone willing to step in. We don't have them, or they are, for whatever reason. If we do not have anyone, then we would be referred to the public guardian and trustee, so PG&T. So that is an independent agency that is given the responsibility for those decisions. One of the things that my families told me was they had a very, very mentally ill and unstable loved one, and they had to get them to the hospital, or they had to get them services. And they were very overwhelmed. What do we do? So we have 3 different types of services. So we have our primary care, which would be your frontline GP and physician that we would go see. So a lot of times, if it's not a crisis or emergency situation, that's a very good place to start, is with your GP. The GPs of today are very well versed in mental health and medications, and they are a great resource for a lot of the services in the community, and they can make a lot of referrals. So if it's not an acute crisis safety situation, that is a really good place to start. If it is a crisis situation, then usually you will end up in acute care, which is it would be the emergency department at the Montfort, the Queensway, or the Ottawa Hospital. Now, each one of those hospitals is what is called a Schedule 1 facility, which means they have a mental health unit, a psychiatric inpatient unit. So that would be your acute care. Your third level of care is what the Royal is. It's called tertiary health care. So what our specialty is although we can have some acute cases, it's usually individuals that have been in the system for a while. We know that they have a chronic and persistent mental illness. So those are your 3 different levels. A lot of clients will go through the 3 different levels. Does that make sense? You might have experienced this, but when you have an individual that is very ill, do they like to go to the hospital? No. One of the terrible but also fascinating things about mental illness is you can be acutely ill and have no idea that you're sick. Okay? It's very, very interesting. I talked about the broken leg. So if I broke my leg, I'm going to feel pain. Maybe you can see the bone. You can certainly show me an x-ray, right? And I know what a broken leg is. I've seen this before. Chances are I'm going to say, yeah, you're right. I have a broken leg. I'm going to put a cast on. Typical, right? If I have schizophrenia and I have delusions, but those delusions are absolutely 100% real to me, and you tell me that I have a mental illness and I need to go to the hospital, what am I going to say? I'm going to say, you go to the hospital. You're sicker than I am. I don't need to go. I'm fine. It's very interesting. That's called a lack of insight and a lack of judgment. And it's one very difficult part about mental illness, okay? So convincing someone who's mentally ill let's just go to the hospital, it'll be great, we'll get you some help, can be very, very difficult. And most likely, getting them to the hospital, you're going to require some assistance. Not easy to do this on your own. So how do we get to the hospital? Well, you can be brought to the hospital by police and paramedics by the following ways. It can be voluntarily, which is obviously the best way, which we prefer. Doesn't happen as often as we would like. We can get to the hospital under Section 17 of the Mental Health Act, which is where the police are able. So if you're exhibiting very disorganized behavior, maybe you're not wearing proper clothing, maybe you're downtown, you're wandering, they're really worried, it's wintertime, you're not wearing any shoes, you're not wearing a coat, you're talking to yourself, you're beating your head with your hands, something like that, the police have the authority, if they're worried about you, to take you to acute care, because we don't have any acute care or emergency here. We used to, prior to 1997. They can take you to the emergency department. In the emergency department, you will be medically cleared, and if they think that you need a psychiatric assessment, they will transfer you to the PsychEmerge services, or what we call PES. You can get to the hospital by the police through a physician and a Form 1, which we will talk about. And what is probably of a lot of interest to families is you can also get to the hospital by the Justice of the Peace and a Form 2. So when we talk about certification, what we are talking about is an individual that is at risk to themselves or to others, or at risk of neglect of self, and needs to be detained in a Schedule I facility for assessment and or treatment. To be certified, there are very limited and strict circumstances that must be met, okay? And they must meet at least one of the following. Now, some individuals will meet all of them, but you have to meet at least one. You have to be a danger to yourself, a danger to others, and or you are displaying such impaired judgment, which is likely to result in harm to yourself. Now, this also includes neglect. So a lot of our elderly clients that become very, very depressed, they're in their homes, they have spoiled food, there's garbage around, they're not eating, they're not going outside, they're not attending to their hygiene, they might have pets that they're not taking care of. So that would be classified as neglect of self, and that would still be grounds for certification. So involuntary patients, what we talked about, as those are patients that we can detain in a Schedule I facility. So that's one of those facilities that's designated as a psychiatric inpatient unit. It will have a locked door as well. So a Form 1. So a Form 1 is an application for a psychiatric assessment by a doctor. So this can be a GP. So that's where I said with your primary health care is often a good place to start, to enter the mental health system through your GP. Unless it's a crisis or a safety issue, then you would want to enter through acute care. But your GP is usually a very good place to start. If the GP does an assessment and feels that the person is a danger to self, danger to others, or at risk for self-neglect or self-harm, they can fill out a Form 1. A Form 1 is given to the police, and the police will pick up that individual and they will take them to an acute care facility, okay, so one of the emergencies. And under that, once they're cleared medically in Emerge and they're transferred to PsychEmerge, if the physician in PsychEmerge agrees and says, yep, you are at one of these risks or all three, I need to do a more intensive assessment on you. So we are going to admit you to the mental health unit of that acute care hospital. Under a Form 1, you may be detained for that assessment for up to 72 hours. It is exactly 72 hours on that form, so the date and the time is written. And if the person is not placed onto a different form, is the second that form hits 72 hours, that person is free to go. They become voluntary. Okay? Now, just because I'm placed on a Form 1 for 72 hours, it doesn't mean that I'm necessarily going to be detained for 72 hours. Say I was in a psychosis from drug use, and after 48 hours, I haven't had any drugs, my psychosis is gone, I'm feeling back to myself, I'm ready to go home. Then they can cancel the form, okay? And I become voluntary. Also, if the person improves sometimes and gains some insight, and the doctor talks to them and the person says, yeah, you know what, I need to stay here. I need to stay here, I need treatment. Then the doctor will cancel the Form 1, so you become a voluntary patient. But you're willing to become part of that treatment team, and you're willing to stay in the hospital for treatment. Okay? Now, something very, very important to keep in mind is just because someone has been declared involuntary, unless they are also incapable, which we'll talk about, they can refuse treatment. So just because I'm detained for a psychiatric assessment and the doctor orders a medication for me and the nurse tries to give me the medication, unless I have been deemed incapable, I can say, I don't want that medication. Now there's one caveat there. If it is a case of an emergency, so if I come into the hospital, I'm harming myself, I'm at risk of harming others, we have an emergency safety situation, I can be medicated against my will. Okay? But it can only be during that emergency situation. As soon as that situation is no longer there, then I go back to being able to refuse. So a Form 2. If a member of the community, a family member, a friend, a neighbor, a coworker, is concerned for the safety of an individual, and they feel that that person needs a psychiatric assessment, they can apply for a Form 2. Now, this is something that I really feel that is not very well known and understood in the community. So Form 2s are applied for through the Justice of the Peace at the courthouse at 161 Elgin Street. The very important thing to take out of this is that the person applying for that form must provide enough information to that Justice of the Peace to be able to make the decision to sign that form, because this is a very significant event for the person to be picked up by the police and taken to the hospital and held. So that Justice of the Peace is going to really want to know some good, detailed information so that they can sign that form. On the form, on the paperwork, you will be asked about 3 different categories. If you can bring notes, dates, times, if you can have quotes from other family members, from witnesses, anything that you can bring for your case is really helpful. They're going to ask you about evidence of mental illness. What are you seeing? What are the behaviors? Has a diagnosis been made? That can be helpful. If you have one, you might not have one. But if you have one, having that knowledge is really helpful. They're going to want to know the description of the symptoms and the behaviors. Are they responding to voices? Are they having delusions? Are they doing really bizarre things? Are they walking outside in the wintertime without their coat? Things like that. What are they doing? What is the evidence that they are mentally ill? A big one, they're going to want to know if they're a danger to themselves or others. Has the person made suicidal statements? Okay? Gestures or behaviors. What are they doing? Have they threatened or assaulted others? Are others at risk? Is the person making the application at risk? A lot of my families that had to go get Form 2s were fearing for their own safety as well. You need to communicate that. It can be really hard to tell a stranger all of this because it's very personal, but the more information that you can give, the better the chance that that Justice of the Peace will sign that form for you. You'll notice that these 3 categories are very similar to danger to self, others, or self-neglect. That's what they're looking for. Does the person meet the criteria for a Form 1? Okay? Are they failing to care for their own needs? So that's what I'm talking about. Are they going out with no coat, no socks in the winter? Do they have no food in the kitchen? Are they not taking care of their chronic health problems? Are they a risk to themselves? So you will be asked for your phone number and address, and that's so that the emergency department can call you if they need more information. So it's important to provide that. As I said, it's helpful if you come prepared with a list. So maybe if you can document things as they're happening, because sometimes it's hard to remember. Oh, when did Johnny do that? Was that 2 weeks ago? No, I think it was 3. Quotations is good. We really need some rich information. If you have any medical terminology, that'll be helpful for the emergency department. Okay, you don't have to be a doctor, but if you know that they've been diagnosed with schizophrenia, or they've been diagnosed with a manic episode in the context of bipolar, they're having delusions, hallucinations, they're having command hallucinations. If you know this information, then that will be helpful for the emergency department once they arrive there. Definitely want to include any information regarding use or access to any sort of weapon, okay? A history of violence, history of interactions with the criminal justice system. Substance use is important, okay? Are they suicidal? Things like that. And also the last known whereabouts is very important if you have any information on that. Contacts, things like that. And I forgot to include, but they'll probably ask you for a description of the person. What were they last seen wearing? Do they have any tattoos? Do they have any piercings? Things like that to identify the person. So with this form, you make your case to the Justice of the Peace. And they can either agree with you or they won't agree with you. In my experience, most of the time they agree. Okay. They will sign a Form 2. So now a Form 2 has been signed. They will fax that to the police. And the police, with that, will now go and find that individual and transport them to a Schedule I facility. So acute care, the emergency department. So as I said, the person will go through regular emerge first. They'll be medically cleared. Then they will be transferred to psych emerge, where they will meet with the psychiatrist. During that assessment, the psychiatrist will read all of the information on the Form 2. They will interview the individual. If you know that the person is now having the assessment, if you are present and you can provide collateral information, that can be a real game changer. It really can. Unfortunately, a lot of individuals can actually present quite well when they get to Psych Emerge, when they do not want to be put into hospital. So having somebody there to say, hey, no, this is not what Johnny normally looks like, okay? This is not Johnny right now. A lot of times, sometimes just having them there for a few hours, they can't keep that up for that long. It's exhausting when you have hallucinations, delusions, and you're very, very ill, and you've got to really hold it together. So a lot of the times, even though it looks like they're holding it together, just we'll give it some time as well. So that physician will either issue a Form 1, so that Form 2 will be canceled, and they will go on a Form 1, and they will be detained in that Schedule I facility for up to 72 hours. Or the physician will say, nope, you can go home. This is where a lot of the anger that I talked about from families came from. If you know your loved one and you absolutely know that they need help, and they get sent home after you've spent all day getting the Form 1 or the Form 2, and there's been this traumatic apprehension by the police, and they're angry at you now because the person's going to be angry. They're going to know that you got that Form 2 and all of that, and then the doctor tells you that they're fine. What do you do? What do you do? Very difficult situations. Hopefully, the psychiatrist will agree with you, and they will be admitted on the Form 1. So we've gone through Form 1 and Form 3, or Form 1 and Form 2. And so Form 3, it's very similar to a Form 1, but instead of lasting up to 72 hours, it can last up to 14 days or 2 weeks. Now, just like a Form 1, it can be canceled at any time. So just because you're placed on a Form 3 doesn't mean you are going to be on that Form 3 up until the last minute of those 14 days, okay? Now, to protect somebody from being detained who shouldn't be, so we have a little safeguard in there, in that the physician that placed you on the Form 1 cannot be the same physician that places you on the Form 3. So you have to be seen by a second psychiatrist, and then they have to give their opinion on whether you need to be detained for further treatment and assessment in a Schedule 1 facility. When you've been placed on a Form 3, the patient themselves will be given a Form 30. And this form basically outlines why and the reasons why the physician is now going to detain you in the hospital under the Mental Health Act and law. I learned really quickly, never give the patient the original copy. I got that ripped up and thrown at me really quickly, and here I am trying to tape it all together, photocopy it, put it back on the chart. Yeah, that was great. As a new grad, I was absolutely horrified. And it's funny, when I finally told one of a really senior nurse, and I was just horrified, and she goes, happens to everybody. She goes, make 3 copies next time. Keep 2 in your pocket. So I did. Because a lot of times a person, they've already been in the hospital for 72 hours. They don't want to be there. So this is not good news. They're hoping that the physician's going to cancel the Form 1, or the time's going to run out and they're going to turn voluntary. So when the physician, it has to be the physician, but a lot of times they'll refuse to take it or something like that. Then they'll want to see it later. And this is when I came in with the original to give it to them. So it will outline exactly why, the reasons, and how that they meet those 3, one of those or all of those criteria. So threat to self, threat to others, self-harm and neglect. Very important, the patient will receive legal advice. So as soon as the person's placed on a Form 3, on a Form 4, or a 33 that we're going to talk about, which is when they are made incapable for treatment decisions, they have to be seen by legal rights advice, which tells them exactly their rights under the Mental Health Act and law, and whether they want to waive an appeal, which means, okay, I'm not going to fight this, I'm going to stay, or they're going to appeal. So as soon as the physician writes the form, we fax off to legal advice, and often they're here in the hospital within a couple of hours, and they have to see the patient. So your rights advisor consults with the patient regarding his or her rights under the Mental Health Act within 24 hours of the patient being placed on a Form 3, 4, 33, or a community treatment order. Explains the significance of the situation and the right of that individual to appeal. Patient has the legal right to expert advice, but as I said, may waive this if they decide they're not going to fight it. If they do appeal and contest the form, it is referred to an independent tribunal, a consent and capacity board, and they review the decisions affecting the patient's rights. Now this can take quite a while. This can take a few months. So if the person does appeal, they need to understand that this means they will be in the hospital awaiting all of this tribunal, unless they decide to stop the appeal and waive. Often, it goes a lot quicker if they decide to stay in the hospital and accept treatment, because then they're usually actually improved and off the form quicker than if they appealed. That's in my experience. If it does go to the appeal board, the entire team comes together. So the person will be appointed a lawyer, and there will be meetings between the psychiatrist, the whole treatment team will be brought in, okay? And the person themselves will be brought in. There'll be a lot of meetings, and then there will actually finally be a decision on whether the person is successful in the appeal and they are not on the form anymore, or whether the form is upheld. So another form, it's a Form 4. So a Form 4 is actually a certificate of renewal of a Form 3. So I can't go from a Form 1 to a Form 4. I have to go 1 to 3 to 4, okay? And I can't go from voluntary, all of a sudden you're on a Form 4. So there is this process, and that is to protect the individual and make sure that their rights are being protected and they're not being detained unnecessarily in the facility. So we have the first renewal, which is 30 days. Then we have our second renewal, which is 60 days. We have our third renewal, which is 90 days. And at each renewal, they get legal advice, and they can appeal that at any time. And the Form 4 may be renewed after we reach the 90 days indefinitely. The longest I have seen a client on a Form 4 was 7 months. During that time, she refused all treatment. So she was appealing the form. She was appealing, we were trying to prove that she was incapable for treatment decisions, which we're going to talk about. And she appealed both of those. So during that time, she was able to refuse treatment. And that's why we were there so long. When we did win that she was incapable, okay, then we were able to treat her. And after a few months, she actually did improve. But the longest I've seen someone on a form, in my experience, is 7 months. So we're going to be talking about treatment and capacity and consent. So treatment, with the exception of emergency situations, so that's that emergency situation where in the moment the person is a threat to themselves or others, and we need to intervene. With the exception of that, all treatment requires informed, capable, and voluntary consent. So that means that somebody couldn't come up to me and say, Sherri, you're going to take that pill right now. When you're a nurse, it's drilled into you, informed consent. So even if I'm going to take someone's blood pressure, I'll say, can I have your arm to take your blood pressure? And they put out their arm, so there's informed consent. They're letting me do that, right? So in Ontario, under the Health Care Consent Act, a healthcare provider needs a person's informed consent or permission in order to deliver any treatment or any intervention. To give, now this is where capacity comes in, to be able to give informed consent, I need to be capable of making a decision, and I need to be given information about my health condition, the treatment that's being recommended, and my likely outcomes of both taking the treatment and refusing the treatment. So an example of this that we do a lot in my program is around ECT, so electroconvulsive therapy. So I might have a client in a very major depression. We've tried a lot of different medications, the depression is not lifting, and the psychiatrist thinks that ECT will work for that person. So the psychiatrist, under the law, has to get my informed consent. So they need to be absolutely sure that I am capable of making a decision for myself. They need to give me all the information about the treatment. So we give pamphlets, we give videos, we talk about the treatment, we might have them speak to somebody else who's been through the treatment, we go through all the risks, side effects, we give them as much information as we can. The person then we even give them a day to go and think about it. Talk with their families, because ECT is a medical procedure, and they come back. And they'll either say, yes, I want the treatment, I understand, and the psychiatrist will ask again, do you understand the risks? Do you understand the benefits? This is what you want. And the person will say yes, and then they will sign an informed consent and release for this treatment to happen. So same as if you were having surgery in a hospital. The issue comes when the person is not able to make a decision. We can't be sure that they can understand the risks and the benefits and their own health condition. So if they can't understand their health condition, they can't understand the risks and the benefits, and they can't make a good decision, well then what we're going to do is we're going to move down the road to declaring them incapable. So capacity to consent. So what I just spoke about, capacity is defined by the Healthcare Consent Act as understanding the information that is needed to make a decision and the ability to appreciate the consequences and or the risks of that decision. So if I can do that, we're good to go. If I can't, but I still really need that treatment, we're going to have to go down a different road. Now, every person under the Healthcare Consent Act is presumed capable. So I will presume that you are capable. If I am the psychiatrist, I will presume that, unless you show me otherwise. Okay? All right. It's not the other way that I'm going to presume everybody is incapable and you have to convince me that you're capable. I'm going to presume that you're capable unless I have knowledge or you show me that you cannot appreciate the risks, the benefits, understand your health condition. So if the psychiatrist interviews the individual and they can't meet those conditions, then the physician, if they truly believe that the person does need this treatment, so say the person says, I don't want ECT, but I can't appreciate the consequences of what will happen if I don't have it. I can't understand that I'm ill. I have no insight and judgment. I'm not making good decisions for myself. Then the physician will place me on a Form 33. At that point, the physician will search for an SDM. Okay? Someone, power of attorney, who will make those decisions for me now. The physician will, once that is secured, the physician will now approach the SDM for decisions for my treatment. So they will no longer approach me anymore. Now remember, Form 33, I can appeal this because we need to make sure the client is protected as well. So I'm going to receive legal advice and I can appeal this if I want. So as I said, the person will receive rights advice and they can appeal this, and if a lot of times they do appeal it. So what do you do if my family member refuses treatment? Well, as we talked about a little earlier, the one very interesting but very difficult part of mental health is you can be very mentally ill and have no idea. You can have absolutely no idea that you are ill. So trying to convince somebody who has no idea that they're sick, that they need to go in for intensive treatment, is very difficult. Okay? If I absolutely believe that I am fine, and you try to get me in a car to take me to the hospital where I'm going to be stuck and locked there, and people are going to try to give me pills that I don't need the pills, you need the pills. You take the pills. Many a time, and I grew very thick skin when I worked in the inpatient unit because I would come in with my pills and hi, Mr. Smith, I'm Sherri, I'm your nurse today. I'm here with your morning medication. I don't need that. You take it. No, Mr. Smith, this is your medication. I told you I don't need that, and smack it away from me, right? Right? I'd be rich if I had $1 for every time that happened. Yeah. So that is called a lack of insight and judgment. So if a lack of insight is not appreciating that I'm ill, and judgment is making good decisions, can I have insight and not have judgment? Or can I have judgment and not have insight? Can I have one without the other? You can. So if I have no insight, so I really don't think that I'm sick, right? But my psychiatrist, I really trust her. And I don't know why she thinks I'm sick again this time, but she really wants me to take this medication. And my family really wants me to take the medication. And I'm just tired of them hounding me all the time because they're always on me about this. So you know what? What the heck? I'm just going to take the medication and get everybody off my back. So that is some judgment, but I still have no insight. Now, a lot of times you don't have either. So I'm not taking that medication and I'm not sick. That's really, really hard. Do all people that lack judgment with mental illness, do they all get the judgment back and the insight? No. Sometimes it doesn't come back. So sometimes it's a chronic symptom of their mental illness. If that is the case, we might move to what is called a community treatment order, or a CTO. So a community treatment order, or CTO for short, is an order issued by a physician and agreed upon by the individual or their SDM, which allows the individual to receive care and treatment in the community. So this is separate from being in the hospital. And it's much less restrictive than being detained in the Schedule I facility. So with our model, since the 1970s, of treating individuals in the community, and that's really where we do most of our work, we really want individuals to get back into their homes, to get back into their lives. We don't want, it's not like the 1800s where we would send them to the asylum and lock them up, right? However, the person needs to be well enough to do that. And if they lack insight and judgment, we might need to help them with that. So it's basically a legal agreement that is drafted, and we have a CTO coordinator. Each hospital has one. And it's a legal document that the physician and the treating team stipulates in this agreement exact conditions that the person must meet, and they can stay in the community. It's not just for anybody, that's for sure. It's for someone usually who has been admitted multiple times to the hospital, is stabilized, will be discharged a lot of times because they lack that insight, will go off their medication, they get sick again, they come back into the hospital, they get stabilized, they go out of the hospital, they go off their medication. So it's for someone like that, right? That can get better with medication, but they lack the insight and judgment to continue on their medication and with their treatment. So that's what a CTO is really made for. What is outlined in the CTO is exactly what the client needs to do. So it's going to name the treating physician, the primary clinician, or the primary worker that will follow the person in the community. It's going to name exactly how many times they need to come in to see the worker. The physician is going to name exactly what medication they're on. It's going to name exactly when they have to come for their medication. It is all laid out. If the person does not follow this order, then the psychiatrist can issue a Section 17, and they will be brought either to acute care or they'll be brought in to see the physician. Because compliance with medication is a problem, if I don't think I'm sick, am I going to voluntarily get up every day and take my antipsychotic medication? Probably not. Maybe. So a lot of times what we use is what we call a depot medication. And a depot medication is actually an antipsychotic medication in a very special formula. It's in an injectable form. It goes deep into the muscle, so either your ventrogluteal muscle or your deltoid. And it sits in the muscle, and a little bit of the medication is leaked out every day. So I don't have to take pills. Okay? That would be part of the CTO that would say, Johnny needs to report to Sherri every second Wednesday at 2:00, and I will give him his injection. And that would be in the CTO. Now, as the primary clinician, I would need to be available and have that medication for him at 2 p.m. on Wednesday, and he would need to come and see me for that medication. Or as the ACT team, they can bring the medication. So with the depot medication, great thing about depot medication, it only has to be given, depending on the medication, every 2 to 4 weeks. So instead of taking a pill every day, you can come see me, your clinician, once every 4 weeks. If it's a Stena or Abilify, you get a little injection in your arm. Nobody knows, like for young people especially, oh, what are those pills that you have with you? Or you have to remember them when you go somewhere, right? Right. So also for compliance, it's really great. So if the person does not follow the CTO, as I said, their clinician, whoever's following them in the community, like myself, hey, Dr. Smith, Johnny didn't show up today. He's not answering his phone. His injection's due today. I've been trying to get a hold of him. What would you like your plan of care to be? And the physician will make a decision. Okay? If we know where Johnny is, or I've been able to get a hold of mom or something like that, maybe I can get a hold of mom to bring him in. Maybe if I'm on the ACT team, I can go get him at home and bring the injection with me. If Johnny's kind of fallen off the face of the earth, we don't know where he is, he's at big risk for relapse, then we might have the police bring him to the acute care hospital.